So welcome to Unit 12, Abnormal Behavior, Module 65, Introduction to Psychological Disorders. If you're just joining this playlist for AP Psychology, these slides align with Meyer Psychology for the AP course 3rd edition. They're the slides from the textbook. And thank you for joining. This is the beginning of the discussion of abnormal behavior. Clinical psychology is what it is now called as a domain within the College Board AP Psychology course. And it is something that I would say most people think of immediately when they think about taking a psychology class, right? That so much of what people conceptualize as the study of psychology, they think has to do with abnormal behavior. Hopefully, as you've listened to or taken a full class in psychology, you understand that psychology is much more than just the study of abnormal behavior. But with that said, it's still very, very interesting. Now, this is a fairly long module, and I'll do my best to get through it rather quickly. There are quite a few learning targets. The first one is explain how we draw the line between normality and disorder. The second one is contrast how the medical model and the biopsychosocial approach influence our understanding of psychological disorders. Describe how and why clinicians classify psychological disorders and some of the criticisms of the diagnostic labels, of which there are many. Also discuss the controversy over ADHD, Attention Deficit Hyperactivity Disorder, explain whether psychological disorders actually predict violent behavior, and finally describe how many people have or have had a psychological disorder and whether or not poverty is a potential risk factor. So this is a really great quote to think about in terms of when we're thinking about normality and abnormality. Who in the rainbow can draw the line where the violet tint ends and the orange tint begins? Distinctly, we see the differences of the colors, but where exactly does the one first blendingly enter the other? So with sanity and insanity. Excuse me. That is a really good thought to keep in mind as we talk about abnormal behavior, clinical psychology in general. Understanding the line between abnormal and normal is very blurry. It isn't cut and dry. And there's a lot of clinical judgment that is involved in terms of diagnosis of different disorders. So if you come into this thinking it's easy, you can just go get a test to see if you have depression, you can go just get a test to see if your child has autism or something like that, that isn't the way that it works. There's a lot of clinical judgment involved. So what is a psychological disorder? It's a syndrome marked by a clinically significant disturbance in an individual's cognition, emotion regulation, or behavior. Significantly disturbed, and that's the word you need to keep thinking about. Significant disturbance, clinically significant, abnormality, that kind of thing when we're thinking about diagnosis of disorder. Significantly disturbed thoughts, emotions, or behaviors are dysfunctional or maladaptive. They interfere with normal day-to-day life. So if the disturbances are just there, but the person is able to kind of get along fine in life and it doesn't really have an effect on everyday day-to-day life, it's probably not at the threshold of the need for a diagnosis of a disorder. But if it interferes significantly with normal day-to-day life, then it probably is. For instance, believing your home must be thoroughly cleaned every weekend is not a disorder. Probably highly recommended, actually. But if cleaning rituals interfere with your ability to work and have fun, that could be a sign of disorder. So can the definition of significant disturbance change over time? For sure. So from 1952 through 1973, homosexuality was classified as a psychological disorder. As of December 10th, 1973, it was no longer classified. The American Psychiatric Association, often in this class we talk about the APA as the American Psychological Association, but there's also the American Psychiatric Association who creates the DSM, which we're going to talk about. They made this change because more and more of its members no longer viewed same-sex attraction as a psychological problem. However, the stigma and stresses that people who are gay, lesbian, transgender, and gender nonconforming often experience can, in fact, increase the risk of mental health problems. So thinking about the history of how mental disorders were conceptualized throughout time. And unfortunately, there's a lot of bad history here. In the Stone Age, drilling skull holes like these may have been an attempt to release evil spirits and cure those that had some sort of mental disorder. They called this trephining. In the Middle Ages, mental illness was believed to have been induced by the devil and required a harsh cure that would drive out the demon. People considered mad were sometimes caged or given therapies such as genital mutilation, beatings, removal of teeth or parts of their intestines, or transfusions of animal blood. Some really horrifying history in this area from long ago, and actually some that's not that long ago. What were some efforts at reform at the turn of the century? Well, thank goodness for Philip Pinel. He was a reformer in France who he was just abhorred by the treatment of mentally ill patients in the hospitals within France, in the Salpêtrière or Bicêtre, or maybe both, I can't remember which hospital it was. He was very opposed to this, and he tried to make some reforms and create opportunities for the mental health patients to have, sort of better lives. So what's the medical model? It's the concept that diseases, in this case psychological disorders, have physical causes that can be diagnosed, treated, and in most cases cured, maybe in a hospital. By the 1800s, researchers discovered that syphilis, which is a sexually transmitted disease, infects the brain and distorts the mind. Before that, they had no idea of those effects, that would be, you would see these mental health effects from that physical disorder. Researchers began to look for physical causes of other mental disorders and for treatment that would cure them. Excuse me. Hospitals replaced asylums, as they were once called, and the medical model of mental disorders was born. So what is the biopsychosocial approach to understanding mental illness? Now, remember, in this class, if you've listened to a lot of these modules through all of the units, over and over again, we talk about the biopsychosocial model. So in terms of mental illness, biological, psychological, and sociocultural influences together sort of weave the fabric of our behaviors, our thoughts, and our feelings. As individuals, we differ in the amount of stress we experience, and we differ in how we cope with the stressors. Cultures also have play a part. Cultures differ in their sources of stress and in their traditional ways of coping. So what are the biopsychosocial factors that influence mental health in terms of the biological ones? We think about evolution or individual genetics, our individual brain structure and chemistry. The psychological influences would be stress, trauma, that concept of learned helplessness. Think back to Martin Seligman's study with the dogs, mood-related perceptions and memories. And of course, sociocultural influences also have a large impact on us and our mental health, the roles that we are expected to have, just expectations placed on us by our cultures in general, and sort of the definition of what is that normality versus abnormality. Today's psychology studies how biological, psychological, and sociocultural factors interact. It's this interaction to produce these specific psychological disorders. The vulnerability stress model, often called the diathesis-stress model, came out of the biopsychosocial approach. And this model suggests that genetic predispositions, so who we are at a genetic level, what has been passed down to us through our genes, combines with our environmental stressors to increase the likelihood of developing a psychological disorder. So this is very much an interactionist kind of perspective, interaction between our nature and our nurture. So epigenetics, we've mentioned this a couple times in this course as well, which is a fascinating area of study. It's the study of environmental influences on gene expression that occur without a DNA change. So we often think about nature versus nurture, but this is sort of a confluence of nature and nurture together. This whole study of epigenetics is really something that we're learning a lot about, especially in the past decade or two. It's just been the amount of research in this area is fascinating. Research on epigenetics, which literally means in addition to genetics or on top of the genetics, supports the vulnerability stress model by showing how our DNA and our environment interact. In one environment, a gene will be expressed. Okay, so what that means is, that if someone's in a really stressful environment, some sort of psychological disorder, some sort of genetics, and it's probably, polygenic variants. It's never, there aren't in many cases of it being single gene expression, it's polygenic. A gene will be expressed, but in another, it may lie dormant. For some, that will be the difference between developing a disorder or not developing it, right? So even if you have the genetic background of you have that within your genetics, if you aren't exposed to the particular environment that would elicit that, you may not develop that disorder. So why do clinicians classify psychological disorders? In biology, classification creates order. So to classify an animal as a mammal says a great deal. It tells you that it's warm-blooded, has hair, produces milk. In psychiatry and psychology, the classification is in order to help and describe the symptoms. For instance, to classify a person's disorder as schizophrenia suggests that the person talks incoherently, has bizarre beliefs, shows either little emotion or inappropriate emotion, or is socially withdrawn. It gives you sort of a framework to be thinking about. But what beyond describing symptoms is the purpose of diagnosis? Okay, so it gives us a little bit more than that. It gives more than a thumbnail sketch of a person's disordered behavior, thoughts, or feelings. In psychiatry and psychology, it aims to predict. So part of it is that we want to use it as a prediction model of a disorder's future course, suggest appropriate treatment, and prompt current research into its causes. So according to this kind of idea, to study a disorder, we must first name and describe it. So the Diagnostic and Statistical Manual of Mental Disorders, sort of the Bible within psychology and psychiatry and mental health in general. The American Psychiatric Association's DSM-5, that's what it's always called, is a widely used system for classifying psychological disorders. So it's the 5, it's in the 5th edition. Mental health professionals use the detailed diagnostic criteria in the DSM-5 to guide diagnosis and treatment. So what are some of the changes? There have been some changes over time for sure, some pretty big changes between the different editions of the DSM. And that's something to keep in mind, that these things change. They're not cut and dry. There's a lot of blurriness in terms of diagnosis. So the conditions formerly called autism and Asperger's syndrome were combined. There's no longer a diagnosis of Asperger's syndrome. It's all combined under the label of autism spectrum disorder. And there are different sort of levels of autism spectrum disorder. Mental retardation became intellectual disability, and new disorders were added, such as hoarding disorder and binge eating disorder. Are some diagnoses controversial? Yes, for sure. Disruptive mood dysregulation disorder is a new DSM diagnosis for children who exhibit persistent irritability and frequent episodes of behavioral outbursts 3 or more times a week for more than a year. So will this help? There's a lot of kids that may be able to be classified as this, or will it turn into sort of typical temper tantrums becoming a mental disorder and potentially lead to over-medication? That's really a question, and it's something really concerning to a lot of people. So what is one criticism of the DSM-5? So critics have long faulted the DSM for casting too wide a net and sort of bringing almost any kind of behavior within the compass of psychiatry. Some psychologists believe that the DSM-5 is an even wider net, and that it will extend to pathologizing everyday behavior. So things that we may not seem to meet that threshold for clinically significant disturbance could end up being pathologized by the DSM-5. Another concern critics have is that over-labeling of what may be common everyday feelings and actual practical responses to trauma in everyday life could happen. That could be really problematic. For example, the DSM now classifies severe grief following the death as a possible depressive disorder. Critics suggest that such grief could instead be called a normal reaction to tragic life events, right? Because that is, to be seriously grieving over the death of a loved one is a normal reaction to a tragic life event. So what is the benefit of labeling disorders within the DSM-5? For those who experience these challenging symptoms, diagnosis and treatment can be a relief and improve functioning. In psychiatry and psychology, excuse me, classification also aims to predict, right? That prediction model. We want to be able to predict and suggest appropriate treatment. So according to this model, to study a disorder, we must first name and describe it. But how can diagnostic labels be misleading? Once labeling a person, we might feel or view that person differently. Labels can change reality by putting us on alert for evidence that confirms our view. We've talked a little bit about confirmation bias, and we will more so even when we get to social psychology, but when someone has a diagnosis, to some extent, it can change our view of that person. In a classic study, teachers who were told certain students were gifted then acted in ways that elicited the behaviors they expected. Labels can be self-fulfilling. So what research has been done in this area? Well, David Rosenhan and 7 of his graduate students went to hospital admissions offices complaining falsely of hearing voices saying empty, hollow, and thud. Apart from this complaint and giving false names and occupations, they answered questions truthfully. All 8 healthy people were misdiagnosed with disorders. How did being labeled as ill impact how others view the grad students and viewed grad students? Until being released, an average of 19 days later, those 8 patients showed no other symptoms. Yet after analyzing their quite normal life histories, clinicians were able to discover the causes of their disorder, such as having mixed emotions about a parent. Even routine note-taking behavior was misinterpreted as a symptom. So how do labels have power in everyday life? Getting a job or finding a place to rent can be a challenge for people recently released from a psychiatric hospital. Label someone as mentally ill and people might fear them as potentially violent. That reaction might fade as people better understand that many psychological disorders involve diseases of the brain, not failures of character. So public figures have actually helped. They've helped foster understanding by speaking openly about their own struggles with disorders such as depression or substance abuse. So on the picture on the right, during his campaign, Boston Mayor Moulton Walsh spoke openly about his past struggles with alcohol. His story of recovery helped him win in 2014, the closest Boston mayoral election in decades. Iron Man, mental illness in Hollywood. Old stereotypes are slowly being replaced in media portrayals of psychological disorders. Recent films offer realistic depictions. Iron Man 3 portrayed a main character shown at the right with PTSD, post-traumatic stress disorder. How has broadening the diagnostic criteria of ADHD created a controversy? So ADHD is Attention Deficit Hyperactivity Disorder, and the DSM has broadened the criteria. For those who experience these challenging symptoms, diagnosis and treatment can be a relief and bring improved functioning. However, critics suggest the criteria are now too broad and may turn normal childish rambunctiousness into a disorder. So how frequently is ADHD diagnosed? Well, it's twice as likely to be diagnosed as boys than as girls, boys compared to girls. Those are the percentages in terms of 4 to 17-year-olds, it's 11%, and 2 to 5% of adults. What are the symptoms of ADHD? Inattention and distractibility, hyperactivity, and impulsivity. So what are the arguments regarding the diagnosis of ADHD? So if you have a really energetic child plus a school situation that may be rather boring for that child, it leads to a problem with ADHD overdiagnosis. Children are not, so these are some of the arguments. Children are not meant to sit inside for hours in chairs. The youngest children in a class, if you have a late birthday, tend to be more fidgety and more often diagnosed. Older students may seek out ADHD prescription drugs thinking that it will help them get better grades. What we don't know, what are the long-term effects of these treatments and why has there been such a huge increase in this diagnosis? So what do the supporters say? Well, more diagnosis reflects increased awareness. ADHD is a real neurobiological disorder whose existence should no longer be debated. It's associated with abnormal brain structure, abnormal brain activity patterns, and future risk of antisocial behavior. That would be what the supporters say. How can it be treated? Well, it can be treated via stimulant drugs such as Ritalin and Adderall, which actually calm hyperactivity and increase ability to sit and focus, but so do behavior therapies and aerobic exercise. And psychological therapies, like going to a therapist can actually help with the distress of ADHD. So extreme inattention, hyperactivity, and impulsivity can derail social, academic, and work achievements. The symptoms can be treated with stimulant medication, behavior therapy, and aerobic exercise. The debate continues over whether normal high energy is too often diagnosed as a psychiatric disorder, and whether or not there is a long-term cost for using the stimulant drugs that are used to treat ADHD. So do disorders increase the risk of violence? No, most violent criminals are not mentally ill, and most mentally ill people are not violent. The few people with disorders who commit violent acts tend to be either those who experience threatening delusions and hallucinated voices that command them to act, or those who've suffered a financial crisis or lost relationship, or substance abusers. So here's a tip if you are taking the AP exam, that the term insanity actually comes out of the legal system. It's not a term that is used within psychology and psychiatry. Insanity in criminal law means that defendants cannot be held accountable for their actions at the time of a crime, typically due to a mental disorder. It is not a psychological or medical diagnosis, and the term insanity does not appear in the DSM-5. So how many people have or have had a psychological disorders? Well, the NIMH, the US National Institute of Mental Health, has estimated that just under 1 in 5 adult Americans currently have a mental, behavioral, or emotional disorder, excluding developmental and substance abuse disorders, or have had one in the past year. And here's some prevalence rates in the United States. So you can see depressive disorders or bipolar at the highest at 9.3%. And I'll give you a second to look at the rest of those. How prevalent are disorders across the globe? A World Health Organization study based on a 90-minute interviews with thousands of people who were representative of their country's population, estimated the numbers of prior year mental health disorders in 28 different countries. And you can see the United States at the top has the highest percentage of people with mental health disorders. So what are some risk factors for mental illness? So one example of a risk factor for a psychological disorder, poverty, crosses both ethnic and gender lines. The incidence of serious psychological disorders is 2.5 times higher among those below the poverty line. But what are some, let me go back 1 second. So look at some of those risk factors: academic failure, having had complications at birth, having to care for chronically ill people, and on, lots of different risk factors there. But there are also protective factors. There are many protective factors that can help shield people against mental illness: aerobic exercise, economic independence, effective parenting, reading, literacy, problem-solving skills, those kind of things. There are protective factors to help protect people from developing mental illness. Does poverty cause disorders? Or do disorders cause poverty? Well, this is a question. It is sort of both, though the answer varies with the disorder. For example, schizophrenia leads to poverty, but other disorders may not, okay? The stresses and demoralization of poverty can also precipitate disorders, especially depression in women and substance abuse in men. So we're back to our learning targets. According to psychologists, according to psychologists and psychiatrists, a psychological disorder is a syndrome marked by a clinically significant disturbance in an individual's cognition, emotion regulation, or behavior. Disordered thoughts, emotions, or behaviors are dysfunctional or maladaptive, interfering with normal life. So that's very key when we're diagnosing. The disordered thoughts, emotions, or behaviors have to interfere with sort of normal day-to-day life functioning. So the medical model assumes that psychological disorders are mental illnesses with physical causes that can be diagnosed, treated, and in most cases cured through therapy, and sometimes in a hospital. The biopsychosocial approach assumes that 3 sets of influences, biological, psychological, and sociocultural, interact to produce those psychological disorders. Culture-specific disorders excuse me, the vulnerability distress model and epigenetics all provide insight into ways in which biology and environment interact and make it more or less likely that a person will develop a psychological disorder. So the APA, American Psychiatric Association's DSM-5 contains the diagnostic labels and descriptions that provide a common language and shared concepts for communication and research. Classification helps psychiatrists and psychologists to predict a disorder's future course, suggest treatment, and prompt research into its causes. Some critics, though, believe the DSM-5 casts too wide a net and it may pathologize typical normal behaviors. Other critics view DSM as diagnoses as arbitrary labels that create preconceptions that bias perceptions of the labeled person's past and present behavior. So there's some controversy over ADHD and how it's treated. The controversy centers around on whether the growing number of ADHD cases reflects overdiagnosis or increased awareness of the disorder. Long-term effects of stimulant drug treatment for ADHD are not yet known, which is another big concern. So most violent criminals are not mentally ill, and most mentally ill people are not violent. People with disorders, though, are more likely to be victims than attackers. Whether people with mental disorders who become violent should be held responsible for their behavior raises moral and ethical questions. Psychology and law often work together hand in hand to determine the best course of action. And finally, psychological disorder rates vary depending on the time and place of the survey. In one multinational survey, rates for any disorder range from 6% in Nigeria to 27% in the US. Poverty is a risk factor. Conditions and experiences associated with poverty contribute to the development of psychological disorders, but some disorders such as schizophrenia can actually drive people into poverty. So that is it. Thank you for listening. Take care.